Welcome everybody to our latest On the Road stop. We are in Sarnia, Ontario, a key border city in our province, the largest city on Lake Huron, located right on the southern tip of that great lake. And like many cities in this province, they are wrestling with the growing crisis of opioid addiction. Here to discuss this issue, we welcome Brian White, Sarnia City Councillor, Detective Constable Mike Howell of the Sarnia Police Service, Dr. Del Donald, Medical Director at the Blue Water Methadone Clinic, Kathy McFarland, Director of Mental Health and Addiction Services at Blue Water Health, and Lori Hicks, a mother who has a very personal and tragic connection to this issue. And we thank all of you for coming here to Lambton College, which is our home base for our time here in Sarnia. It's good to be with you all here this evening. Here are some numbers representing Lambton County as a whole, which includes the city of Sarnia, and these are the most recent years for which we have data. Let's bring these up, Sheldon. In the year 2012, there were 6 deaths from opioids. In 2013, that number jumped to 11, 5 of those being from the painkiller fentanyl. In 2014, it dropped back down to fewer than 5. Now, 5 deaths may not seem like much, but that is 4 times the province-wide rate. And compared to the rest of the province, Lambton residents were 3 times more likely to visit the emergency department because of opioids. Okay, Dr. Donald, you get us started on this. Let's start with some basic definitions. Fentanyl, what is it?
Fentanyl is an opioid. Opioids are drugs that work in the opioid receptors in the body. There's natural occurring opioids like morphine, and then there's synthetic opioids like fentanyl.
And why would you take it?
Well, I mean, fentanyl is used quite extensively in medicine. It's a synthetic opioid. It's shorter acting than other opioids. So if you have a procedure you want to do that you don't want to have the opioid effect, you can use it intravenously. It's shorter. It's very powerful. It doesn't cause as much nausea as some opioids do.
So it's a good painkiller?
It's a very good painkiller, yes.
How does it compare to heroin?
Haven't ever used heroin in medicine, but it's about 40 to 50 times stronger on a milligram basis than heroin.
40 or 50 times
Yes.
stronger than heroin.
And about 100 times stronger than morphine.
Okay, Brian, how big an issue is fentanyl abuse in Sarnia?
Well, it's huge. It's a big problem. You gave us some of the numbers. Obviously, what we're going to hear more from some of my colleagues here about is some of the effects that we see in the community throughout. So, obviously, we're dealing with the very obvious, the deaths, the sicknesses, but we're also dealing with the other aspects of what it means to be addicted or to use fentanyl and other drugs of the same class. We're talking about perpetuation of criminal activity, of course, that's going to be rampant. Certainly more brazen attempts right now that we seem to be seeing through the community. But beyond that, we're seeing, because of the grip that it has on the number of people that it has, we're seeing the perpetuation of mental health concerns and the inability of folks to get past the initial concerns that we all have, which is the drug of choice, whether it's fentanyl. Years ago it might have been Percocets, and now we talked about oxys, and now we're up to fentanyl. Obviously very deadly, but when we're addressing those issues, we're unfortunately left with fewer resources to deal with the actual mental health aspects of what's going on.
Okay, well, tell me why it would be more of a thing here than anywhere else in the province of Ontario.
Well, I think we're all trying to figure that out. I think, even for alcoholism, we have a pretty high rate of alcoholism in this community. So it's not, when we're talking about addictions themselves, we're not necessarily limited to just the opiates that are on the street. But at the same time, we have to face this reality. And my best guess is we're dealing with a lot of hopelessness in our community. We've had an economic downturn that's lasted a significant period of time here.
And that contributes to it?
Oh, absolutely. Absolutely. When people are faced with the sense that perhaps this isn't the place for them, but they're stuck here anyways, which is a perpetuating feeling amongst a lot of people, it leads to the desire to cover up that mood.
Let me follow up with Kathy on that. Do you have any theories as to why it would be worse here than other parts of Ontario?
I think that some of the work that we did to understand what are the needs of our community and what's going on. When it comes to our services, more people report, 58% when they go into service say that they have a problem with alcohol. And they have polysubstance issues. So it's alcohol, 58%, and 30% state that they are using opiates or crystal meth or cocaine and crack are about 17%. So there's this sort of grouping of 3 at 30%, 58% with alcohol, and cocaine and crack at the bottom.
Detective Constable, you were on our program once before. You came all the way into Toronto to talk about this several months ago. It's probably longer ago than that now. How long is it?
I think it was October.
Last October, okay. Is there a particular group, as you look at it, a particular group of people in this community for whom this is a particularly bad problem?
We're typically seeing with the data that's being provided by Lambton Public Health is all the way from teenagers all the way up to late 40s, early 50s, but primarily the group that we have the highest incidence seems to be in the 20 to 29-year-old group. That's the group that's 3 times more likely to attend our Lambton Public Health or our Blue Water Health for a opioid-related diagnosis. So these are staggering numbers. As you alluded to, the 4.5 times our fentanyl death rate. The statistics can't be denied anymore, and that's kind of what's been brought forward within, I would say, the last year or two, is really increase the awareness about what is going on. That, you know, I think most people have probably had an idea that there's always been a bad drug problem in Sarnia, but I think once the data comes out and they see how we compare to other regions, it's staggering.
You are a hop and a skip away from Port Huron, Michigan.
Yes.
Is proximity to the border part of the problem here?
No, not all. As I've stated before, we're really not in the drug pipelines that other major centers are when you're talking about Windsor, London, Hamilton, Toronto. Any of the drugs that are coming across the border are going specifically to those areas. They're not stopping here. But what you're having in our community is you're seeing it's either prescription opiates or it's crystal methamphetamine is pretty much the drugs of choice here. But when it comes to opiates, fentanyl is the king. It's what every addict seeks out. It has the best high that they've described to me. There's nothing else like it. And that's why a lot of people, once they start to get into that cycle of addiction, can't get out. They seek fentanyl and their lives just cycle around their addictions.
Dr. Donald, I don't want to sound naive about this, but when they say the best high, what does that mean?
Well, you know, I'd have to say that, you know, in my practice, and I have in this community 1,300 patients that I see on a regular basis, and in Chatham we have about 300, Wallaceburg 100. So I've been doing it since 2004. You know, fentanyl, there are people that are real fans of fentanyl. And however, that's not the biggest drug or opioid of abuse in my practice. And it's interesting because these statistics, I'm not saying that they're not true, there's always things that can skew them. For example, maybe we have more people that use the emergency department because they don't have primary care.
So fentanyl is not number one in your experience. What is?
No, it's a problem for sure. But I would say in people that keep using opioids, it would probably be hydromorphone.
So first noticed that it was a problem here.
You know, listen, after OxyContin was delisted, everything changed. You know, and it's a classic example of, you know, if you fix this, you better be waiting for something else.
Law of unintended consequences.
Exactly.
Eh?
So the danger with fentanyl is that what I see anyways is the number of neophytes that use it. You know, that they go from, you know, it used to be, well, if you want to try this oxycodone, either Percocet or OxyContin, you know, you might take it orally, you'd probably snort it. And towards the end, some people were smoking it. But you see, when you smoke a drug, your blood level goes up so fast, even faster than injecting it. And that's where the problem is. That's part of the problem. The other part of the problem is the way opioids work. And the way opioids work is that if there's a threshold above which you start to lose consciousness, the threshold above which you stop breathing is right beside it. Now with alcohol and with cocaine, those are the respiratory depression's not an issue. We've all, and the kids that'll fall down, you'll talk to them and say, well, have you ever passed out smoking fentanyl or seen anybody? At least 40% of them will say to me, yes. But they call it passing out. And it's like, to them, it's like somebody at a party, a 16-year-old or something, we all had this experience, I'm sure, when we were growing up, has had too much to drink and he's sleeping on the couch.
And they don't realize
They don't understand the difference.
Yeah.
You see, the difference is people, when they die from alcohol overdose, it's not because they stop breathing, it's because they vomit and aspirate and can't breathe. And that's really high toxic levels.
This is different.
This is, as soon as you lose consciousness, that is a pre-death experience.
Lori, are you ready for this?
I'm ready.
Okay. I really want to thank you very much for joining us today, because this is not an academic experience for you. Tell me about your son.
My son was, he suffered from 2 health issues. One was a hip injury, chronic pain, and the other was oxy addiction.
How did he have the hip injury?
Hockey.
Playing hockey?
Yeah.
So regular hockey injury.
Yeah, he loved his hockey, and it never repaired, just kept getting worse and worse. So when he first admitted to the addiction of the oxy, he was in and out of rehab. We got him into rehab, he would be home, relapse, another rehab, back home.
But I guess the point that needs to be made is your son was put on this drug by a doctor
Not
to manage
the oxy, no.
Not the oxy, but
No.
what did he first go on to manage his pain from his hip
Nothing.
problems? Nothing. He just
Nothing.
dealt with that.
Yes. Yeah.
Okay.
So after his 3rd rehab, and he come home, things were good, his life was going to get back on track. He ended up moving out of town and got a full-time job. Now that his life is getting back together, now we can deal with the pain and have his hip fixed. So he was scheduled to see a specialist, and his appointment was 18 months down the road. So we were told in between, take him to a pain specialist, manage the pain. He's got a long time before he sees a specialist and has surgery. So we did, and I went with him, and the doctor put him on fentanyl. And I said to the doctor, he's a recovering oxy addict. And they said, don't worry about it. We need the fentanyl to control his pain so that he can continue everyday life. He can continue working, do whatever he has to do.
How did he take the fentanyl?
It's a patch. He put it on his hip, and he was to change it every 2 to 3 days. And he did that for a little while, but when I was at the doctor, I said, what about addiction? This is not good. I don't know a whole lot about fentanyl, but I don't think this is good. I said, don't worry about it. We'll deal with the addiction after. We've got to control his pain.
Got to control the pain first.
Yeah. So as a concerned mom, I had a couple questions for the doctor, but he's the doctor. He knows what's best.
Sounds like you asked the right question, though.
I thought I did. Mm-hmm. And it wasn't very long at all that my son started missing work. He was coming home more, and you could see him going downhill real fast.
Because he did get addicted.
Yes, he was not keeping the patch on him. They cut it up and smoke it. And we didn't know all this until his next rehab, but it was a struggle. Then he ended up, he got arrested for fentanyl charges and had said to us, I'm in big trouble. Big trouble. I'm smoking fentanyl every day, several times a day. So the day that we bailed him out of court, his dad took him right to Windsor to detox. Thought, okay, he's already done the paperwork for rehab. He had already done that. But 3 days later, they opened the door and sent him home. So to keep your bed in line at rehab, you have to stay clean. You cannot enter the rehab if you don't have at least 3 days clean under your belt. So my husband and I watched him 24/7. We didn't want him out of our sight, didn't want him out of the house. We've got to try to do this. And we watched him detox at home, 2 weeks of the worst flu-like symptoms you've ever seen. The sweating and freezing and
DTs, the whole thing.
it was horrible.
Yeah.
It's cruel. It's cruel what he had to go through. But he finally got into rehab in Kingston. And my husband and I, the last time we saw our son was in Kingston. We went down and spent a weekend with him. And he talked and talked and talked. He told us how you get the patches, how easy it is, that people have prescriptions but don't use the fentanyl. They sell it, and the addicts know this guy gets his on the 10th of the month, this guy gets his on the 15th, so you always know where a good supply is going to be, and these people make $5,000, $6,000 a month selling their legal prescriptions.
So what happened in Kingston? He got the treatment he needed?
He did very well. He had 4 months clean, and they had offered him sober living. And so he was transitioning between the rehab and the sober living. And he wanted personal items. He was going from a room of 2 or 3 guys to now he's got his own room. And we knew he was going to come home, but he said, I can only come home for a day. I can't stay in Sarnia. It's toxic. Okay. So we knew eventually he was going to come home for a day. But we were woken up at about 5 o'clock in the morning by police from London saying that they had found our son in a hotel room. He had died from a fentanyl overdose. So it's the power of that drug that you can throw away the hard work on your detox, the pain. 4 months of struggling through rehab, throw it out the window for just one more time or see if I can do it. And we were told by the police that because he had been clean for so long, that it wouldn't have taken much, that his tolerance level would have been so low. And it's instant death.
Lori, how old was he?
25.
25 years old.
Yeah, and this was 14 months ago.
See, there's research that says that opioid dependent, opiate addiction, people with an opioid use disorder, many terms, should not go to rehab without being on opioid support. So either methadone or Suboxone. You know, there's a lot of things they can learn at rehab. They can get away from their milieu, which is super important. You know, as he said, it is toxic.
When he says Sarnia is toxic, he
Well, I
knows
think
too many bad people.
No, I think what he meant is the people he knows.
Yeah, they're all here, and
That's
if
right.
he come home, temptation's at your front door.
Well, you get triggered. It's a concept in addiction treatment. You get triggered, and once that happens, rational thought does not work. It's a different part of the brain that's activated. But the problem is, see, a lot of inpatient treatment facilities will not take people on Suboxone or methadone, even if what you're sending them there for is treatment of their cocaine problem, their alcohol problem, or their methamphetamine problem. They might have their opiate problem under control, but the other problems they don't, and they would do very well in rehab. But because a lot of inpatient facilities are abstinent-based, and abstinent-based treatment it's an ideology. Evidence would say that the very best treatment for someone who's got an opioid problem is to go on opioid like Suboxone or methadone. The problem if you go to rehab is, as the police said, you're very quickly, your tolerance drops off, even in a matter of days.
You wanted to add?
Well, I would say that, you know, the WHO, the recognition of transitions when people move from wherever they are, whether it's abstinence-based treatment or they're in jail and they leave jail, that's a risk point in terms of relapse because they don't have that tolerance, right. And they need to know that they cannot use what they used months earlier or whenever when they had that level of tolerance. That's a really important point.
In addition to that, there's no evidence that inpatient treatment works for opioids. As a matter of fact, if you look at sort of a standard, you know, an ideal system, which we don't always have here, like you say, you can go to detox and then there's not rehab right after. That would be ideal. So if you go to a withdrawal management and then you move right into rehab and you start a 12-step program there and you start aftercare as soon as you get out and you have good family support, the success rate of that treatment at 1 year is under 5% for opioids, okay? Now, it's much better for alcohol. It's probably around 30%, ideally.
Opioids are the toughest nut to crack, obviously.
That's right. It just doesn't work for them. I mean, just like all cancers are the same,
Yeah.
neither are all addictions.
Brian, you wanted to add.
Yeah, well, in some ways, I don't know what the stats are going to say, but in my own experience, I would say that, I mean, a couple things. Addiction is the only disease that you can have that'll tell you you don't have it. So it's not uncommon for an alcoholic to have finished a treatment stay 3 months. I've known many people who've come from a 3-month treatment on a train, pulled over for a stopover somewhere before getting the train to Sarnia, and would hit the liquor store. So I mean, unfortunately, it's not just an opioid problem when we're talking about relapsing. Obviously, the stakes are a lot different. They're a lot more serious when it's an opioid addiction. But at the same time, I think it's fairly common to assume, and you know, again, in my experience, that you're looking at, I would disagree, probably 5, maybe 10% success rate with a 12-step program, even for alcoholism. The point is, though, is that when you get connected with people who are of like mind and have similar stories with you, and who have nothing to gain, no profit, nothing else, no other motivation other than to help somebody who has suffered the same way that they have, then that is a really important aspect of what you're coming home to after. If you're not capable of coming home to that, then perhaps another place.
Lori, can I understand how you feel about the medical community on this one? Because I guess on the one hand, doctors prescribe this because they hope to be able to take pain away from their patients.
Right.
But on the other hand, it sounds like these patches are all over the place, and getting these prescriptions renewed doesn't take a hell of a lot of due diligence.
Our son told us how easy it was. We're talking 16, 18 months ago. How easy it was to get the prescriptions. You could go to doctors out of town, go to another doctor out of town, go to little Bob's pharmacy on the corner, so they're not all hooked up on computers. But the ease of it, the amount of people that have a prescription for chronic pain that aren't taking it, with the amount of money that they're making, they're always going to keep refilling their prescription. That's a pretty nice side income. And it was always available. And he didn't seem to have a problem going and getting a prescription.
Mike Howell, is there anything you can do about that?
We've definitely tried with the Patch for Patch program, and that's really what kind of snowballed all this. Is we were seeing how many incidents of fentanyl abuse were taking place. So once I started to look at the data about how many opioid-related deaths we were having in Lambton County, started to get the process moving of looking at other regions. North Bay specifically has a Patch for Patch, and really they are the...
And what does that mean?
Patch for Patch is basically an exchange program for fentanyl patches. When someone's prescribed a patch, it's typically worn on the skin for up to 72 hours. But when someone consumes the patch, whether it's through addiction, they will break down the patch. And so typically they cut it into strips, they will put it on tin foil, they will apply a heat source with some sort of smoking device or a tube. They get the rush of all that drug all at once. But what it does is it breaks down the patch. So the program basically is about responsible use of these opioids, as well as making sure that these drugs aren't being diverted on the street.
So is the idea you can't get a new patch unless you bring in the old patch?
Absolutely.
So you can't cut it up anymore?
Yes. So if if I'm prescribed 10 per month, I have to return 10 before I'm reissued another 10.
And what if you don't?
Then what happens is there's a conversation that takes place between the pharmacist and the doctor saying that, for example, Mike Howell will only return 4 of the patches. He was supposed to return 10. Something's going on, whether it's a diversion issue, whether it's an addiction issue. And really, it's the checks and balances between getting the issue addressed, getting that person. It's not just about getting someone cut off. That's not the goal of this, is to get someone actually help. So does that person need to go into replacement therapy? Do they need to go into rehab or detox or whatever the case may be?
When did you bring in Patch for Patch here?
October of last year.
And what's been the impact since?
Well, the prices went up 50% that day.
Yeah, once that happened, the old business model of supply and demand, the supply has dramatically shrunk, and the price has gone from typically a 100 microgram patch was $350 to $400 before. Now it's up to $550 to $600. So it's had a dramatic impact. We've had 0 fentanyl-related deaths since that time, which is a great accomplishment. But this is only part and parcel of other programs. We have naloxone that's been being used by our Lambton Lambton EMS. That also came in. So there's multiple effects, and you've also got the Metafie program that has recently been initiated. So you've got a couple of different approaches to this larger problem. So it's been quite effective.
You mentioned a new word there we haven't heard before.
Naloxone. Yes.
Naloxone, what is that?
It's a opioid antagonist. So basically what it does is in the brain receptors, the receptors of the brain for opioids will attach to those receptors. But Narcan or naloxone has a higher affinity than those opioids, which actually when someone is going through a overdose, will actually bump off those opioids off the receptors and replace it with Narcan. So effectively, if someone is going into potentially a fatal overdose, it will reverse that for a period of time, which really allows them to get to the proper medical emergency treatment that they need.
Kathy, let me get your take on patch for patch. Is it working?
I think it is. I think it's wonderful. I think it represents some of the work that's so essential in building our services. Patch for patch wasn't labor intensive. It wasn't extra money. It was providers working together on how to manage safely prescribing and getting those patches back and not finding them on the street. So I think it's a testimony to police, pharmacy, especially, and docs working together.
You're at Blue Water Health, yes?
I am.
How big a place is that?
It is a 369-bed hospital.
Okay, that's good sized. Your hospital is taking part in something, if I got this right, called Metafie?
You are.
META:PHI.
Yes.
What does that refer to?
It stands for Mentoring, Education, and Tools for Addiction, Primary Care, Hospital Integration.
In English, please, Kathy, what does all that mean?
So what it means is, it's really an intent to give best practice care in the emergency department for people facing an alcohol use disorder or an opiate use disorder. It's about building a pathway and a rapid access to addictions medicine. And it's about supporting primary care and return of patients so that primary care can feel supported and care for patients with alcohol or opiate use disorders. And at the same time, it's about pairing any addictions expertise as fast to the point of need as possible.
And how long has it been in place for?
Since March, I believe.
Well, we started the process January 2015.
Having any impact yet?
Well, so 2015 we started it. We finally announced
I should say that Dell is running the RAM clinic. So part of that model includes a rapid access addiction medicine clinic. And when folks come in and they're appropriate for the service, then they're referred to Dell and follow up.
Well, yeah, so the process, it's a 7-site project.
Right.
And I was invited by the guy running it. He asked me if I thought Sarnia would be a good spot. And anyways, part of the thing was getting everything lined up. It took us a while to get it all going. We announced it publicly, or the hospital announced it publicly in March. We were doing a little bit of it beforehand.
Why do you think it's got a better shot at success compared to other things out there?
Well, really what it's about, I'm glad you asked Kathy what it stood for, because I could never remember past mentoring. But it's about realigning existing resources. So we're talking about efficiencies. If you think of any other specialty, you think what happens, and I was an emerge physician for many years, if I saw somebody with a broken ankle, I don't send them to a physiotherapist. I send them to an orthopedic surgeon who sends them to a physiotherapist maybe. And if I see somebody who's got diabetes, I don't send them to a dietitian. I send them to an internist or his family doc.
So the appropriate treatment at the appropriate time.
Well, what's happening is we were not sending people to addiction doctors. We were sending them to addiction services, which is fine. I mean, we're going to send them there anyways if they're interested in this. But it might take 2 or 3 weeks to get in there. And when you're talking about the 2 disorders that we're mentioning, opioid use and alcohol use disorder, both of them are characterized by significant periods of withdrawal. So if someone presents to the emergency department or withdrawal management, they might just walk in there, and they're in withdrawal, if you can't ask them to wait 2 weeks. In this situation, what we do is we've been training the emerge docs to treat opioid withdrawal by giving them, if they're in opioid withdrawal, to give them a couple of doses of Suboxone in hospital and refer them to our clinic. Alcohol use disorder, we've talked to them about evidence-based rapid treatment of alcohol withdrawal and then refer them to our clinic. And you know, I think down the road, this is going to be a dramatic improvement in what's happening.
Lori, I want your take on this. I know this is a hypothetical question, but had some of these programs been around when your son was, do you think the outcome might have been different?
I can't answer that. It would have opened more doors for him. Extra options are always good. But with the way things worked out with our son, unfortunately, it come down to his choice. And the relapse, after you've been clean and you're cutting up a patch, the problem with a patch is you can cut it in 4 pieces or 8 pieces, but you really don't know how much you're getting. So if he had a patch the night that he died, and he took a quarter, he might have got 80% of the medication, not knowing what you're doing. They actually call it Russian roulette when they cut it up. So I don't know if we could have done anything more for him, but I'm all for any other doors that can open to help with the addiction. And I think talking about it is very important too. It's like mental health. We never spoke about mental health freely 5-10 years ago. Yeah. We do now, and that's what we have to do with addiction.
Well, in a strange kind of way, the death of Prince may actually help here, because it has just emerged that it was a fentanyl overdose that killed him. He took too much of it. He was apparently experiencing hip pain as well. So maybe this is getting on a radar screen now in a way that it otherwise wouldn't have because of Prince. I do want to just take a moment here. Sheldon, let's put this up if we can, because we want to see if there are any lessons from other provinces that will be helpful here in the province of Ontario. As we look west, this past April, British Columbia declared a public health emergency. They had 200 opioid-related deaths in just 3 months, and 64 of those were from fentanyl. And I guess, Mike Howell, I want to ask you, are you concerned that that kind of situation could happen here?
Absolutely. It's a bit of a different animal out in the western provinces. They're seeing more of the fentanyl patches, and they're also seeing the powdered fentanyl, which is being imported from outsourcing countries such as China. That is coming in and being added to either counterfeit oxycodone pills, so they're almost cashing in on the old addicts that were using those drugs prior to it being delisted and more or less vanishing to a certain extent. Adding it into that drug and rebranding it and selling it. So it is a different animal there. It is starting to slowly creep into Ontario. There's been cases in Durham region where the fentanyl powder has been added to cocaine. And there's also been cases of it in heroin. You know, and these are the problems that people sometimes may be taking other drugs recreationally and may unknowingly consume this fentanyl powder as well. And from any of the literature of the information I've seen, it's a very small microscopic amount that needs to be added to a pill, for example, to make it fatal.
Well, if you think a milligram of fentanyl powder is the equivalent of 100 milligrams of morphine. Now, if you came into the emerge and you just broke your ankle, I would start an IV and I would give you 10 milligrams of morphine. I know physicians that would only give you 5.
Yeah.
And 10 would probably be a good start. I might need to give you another 10, depending on how bad your break was. So if you're taking 1 milligram of this fentanyl powder and it's 100 milligrams of morphine,
right.
If you're opiate naive, that'll kill you.
Yeah, absolutely.
Now, let's say you're opiate tolerant to a certain degree, but the pill manufacturing machine dumps in 2 milligrams. I mean, because the tablets are an 80 milligram tablet and there's a binder and everything like that. They're the size of a Oxycontin 80. If an extra milligram gets in there, you're now 200 milligrams. So the death rate in Alberta and in British Columbia is from powdered fentanyl. And we can do the patch for patch program, which has really been a great idea. You might as well make use of the fact that this is a medication that you take off after you've used it. I mean, you can't do this with people pills, because they'll say, "Well, I took it. I can't bring them back to you. I took it." Yeah. But what's really scaring me is when we do this, what's the next thing? It could be powdered fentanyl.
Kathy, let me get your take, because we often see British Columbians on the cutting edge of a lot of this type of treatment. There are some experts there who are considering the idea of providing access to regulated doses of pharmaceutical-grade opioids through a supervised facility. Is that a good idea?
Well, it's within the spectrum of what we call harm reduction. And a lot of harm reduction strategies can be very controversial.
Needle exchange, for example.
Needle exchange, or providing alcohol to people with alcohol use disorders. The attempt is to reduce the harm. And knowing that people are going to get the drug and face death, that this is a measure designed to reduce at least the risk of death. I think that when we look at, I'm part of a program that promotes harm reduction, so I think that it's essential for people to embrace any level of risk mitigation that they are comfortable in doing. And it's really about sort of arming people with the knowledge to make good decisions, to reduce their risk, and to get them on a path. And a lot of it begins with getting people comfortable with making a change. When Dell talked about sort of counseling services or residential, not everything is a fit for everyone. And so the big part of this is getting people comfortable with some kind of treatment that can save their life, and some kind of engagement that helps them along a path that can be very complicated. And I think that's what we need to do. And I think part of this program, maybe it's an option. It's about evaluation. It's about, do people stay in this? Do people get opportunity to go down a path moving towards less use, and so forth?
Brian, yours is obviously not the only community in the province of Ontario dealing with this, although you guys are, from what I've been hearing, neck deep in it right now.
That's right.
But give some advice to other communities around the province on what you've learned here and how it could be helpful perhaps for them.
Well, I think some of the things that I could glean from our experiences here, and again, it's hard to get a full 40,000 foot view all the time. I mean, I'm around addicted people every day of my life as well. So their personal stories, I think, are what speak volumes to me. And one of the things that I think is so important is that we, to Kathy's point, is that we have an opportunity here to tailor make the treatment program for the individual that works. I don't like it when I hear that somebody's been on methadone for 2 and 3 years. To me, there's a failure in a reintegration into what their productive life could look like. And having heard from some of those people, that's what they believe as well. When I look for the need for a detox and a treatment facility in our community, part of that is so that if there is an availability of a social network or a family network that could participate in tailor making that treatment program for that person, then I want to see that happen here. And maybe the train ride analogy I used earlier from an alcoholic friend of mine, maybe that wouldn't happen if there's a closer place for them to land when they come out. I guess what I would learn from us is that if you've got a community that doesn't have full resources, but you have a corrections facility, make sure the corrections facility is addressing this as an illness and not a crime. So addiction should not be treated like a crime. Let's hope that I would say patients in the corrections facility have access to 12-step treatment programs, have access to mental health care as are needed. If those resources aren't available, you better be banging down the province's door to make sure that they're there.
Dale, let me get you to follow up. What have you learned here that is important for other communities across Ontario to know?
One thing I have to say is, it's important for other communities. It's also important for me to answer what Brian said. This assumption that people on methadone are not productive is completely incorrect.
I didn't
and
say
all
that.
the data shows. Wait, you said on methadone for 3 years. What's wrong with that? If they keep clean, if they get back with their husband, if they're not on the street anymore, if they're working, if they're back in school, it does not work for everyone. But more than 75% of the people at our clinic that are on methadone or Suboxone are opiate free. That's not everyone, but it's a lot better than rehab does. it is something, unfortunately, that what we see is the support groups around people often suggest the same thing. Why are you still on that? You're fine. You're back to normal. Why would you still take it? And they feel pressure to get off. When they get off, the maintenance therapy is when the problems start. Now, lots of people get off maintenance therapy, and lots of people relapse. What should happen is this should be accepted as it is, which is the standard of care for opioid use disorder. It's considered that by every licensing body in the Western world. It's considered that by the World Health Organization. This is a very complex disease. It's a chronic disease. Nobody asks somebody to get off their insulin. Nobody asks somebody to get off their blood pressure medication. The problem is, as we all know in this room, there is a stigma around addiction, and our patients fight this all the time.
So we need to rethink.
Yes, and
that
every
angle.
community should be supporting addicts, people with these disorders, including those that happen to choose to be on an opiate replacement program.
Well, and that's exactly a point that I'm trying to make in all of this, is that this has to be there. I never would say that there isn't a place for methadone. Maybe, you know, having 3 for-profit clinics in a city this size can be a little concerning, and that's nothing against you. I had to deliberate on another clinic that was operating illegally for a number of years, and then we simply changed the bylaw and suddenly they were legal. I mean, that's a little concerning as to how that stuff perpetuates itself as well. My point is that if that's the only treatment, or the perceived only treatment being given to, again, a number of patients that have spoken to me personally and directly, or a patient, let's say, who's 17 years old and was taking oxys for 3 weeks and then told that they needed to go on a withdrawal management plan with methadone, those things concern me. This is a piece of the puzzle. We need to ensure that the mental health care is there. We need to make sure that for those who are seeking 12-step programs have access to them. We need to make sure that when we're going to detox, when eventually we have a withdrawal management facility here, that we also have a treatment facility in place in this city to make that transition as smooth as possible.
I'm down to my last minute here, and Laurie, I feel I should give it to you. We've had a good constructive conversation here about some of the problems, some of the potential solutions. What do you want people to take away from this discussion?
Opiates and fentanyl will kill you. There is no such thing as just one more time, or trying it for the first time could kill you. With the methadone clinic, it's another option. The Blue Water Health, it's options. The options and the help are there. If you really need help, or you know somebody that needs help, you have to fight to save their life and go to whatever option is available and what is going to work for them. There isn't one solution for everybody, but the drug will kill you.
I want to thank all 5 of you for welcoming us to Sarnia in Lambton County in southwestern Ontario. We're really grateful for your participation in this discussion. Thanks so much, everybody.
Please come anytime. Thank you.
British Columbia recently declared a public health emergency after a surge of fentanyl-related deaths. That designation allows the province to track overdoses in real time. In Ontario, the latest overdose numbers are from 2014, when 173 people died from a fentanyl overdose. Critics say the fact that the numbers are so out of date means they can't get a clear picture of just how bad the problem truly is.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.